Okay, you can start, Jo.
Hello, good evening, everyone. Thank you for joining us today. This is a CME meeting hosted by the South African HIV Clinician Society. I'm Joana Woods, and I'm joined today by my colleague, Bronwyn Bosch. We are going to be discussing ARV therapy and weight gain or weight changes. So we're going to start off with a presentation by Bronwyn, and then I'm going to share 2 case studies. And at the end, we would like to have a Q&A session. So this webinar is recorded, so you can download it from the website. Obviously, there's a lot of you, so we won't be able to take questions or have you live, but you are welcome to make comments and put your questions in the Q&A box. In fact, I'm going to be asking you to make comments, and also know that you are eligible for CPD points. And last but not least, we'd like to acknowledge that the South African Clinician Society would not achieve the results without the support of our donors and sponsors and partners. And this meeting was made possible by the support received by United. All right, Bronwyn, if you'd like to, then you can start your presentation.
Hi, everybody, and thank you for joining us this evening. All right, so let me just share my screen quickly. All right, so we're going to be speaking about antiretroviral therapy and weight gain tonight. I'm Dr. Bronwyn Bosch. I'm part of INTEGRASE. And these are my declarations. All right, so the outline that we're going to follow, we're going to talk a little bit about the background, where we've come from, where we are now, and then look specifically at ART and weight gain. We're also going to go into some of the proposed weight gain theories, and then look at measurements of weight gain, interventions and treatment options, and then just some take-home messages. All right, so to understand where we've come from and where we are now, we need to look a little bit at the history of antiretroviral therapy. So it all started in 1981. There were the first reports of a strange illness in men who have sex with men in the US. And a year later, the term AIDS was defined. But it was only the next year that they actually discovered the virus, so the HIV retrovirus, and this was only given the term human immunodeficiency virus in 1986. But before that, so in 1985, every region in the world had reported at least 1 case of AIDS. And it was only 6 years later that, off the back of a study done in 1986, that zidovudine became available as monotherapy. So it was a repurposed failed anti-cancer drug that had been shelved and brought back out. And then over the next few years, there were other drugs in the same class, so the NRTIs, that were discovered. And slowly new options were developed. And in 1995, we got our first PI, saquinavir. And then a year later, NRTIs were discovered and nevirapine was approved. So it took quite some time before we got ARVs and got enough treatment options where we could use combination therapies as a standard of care. In 1997, we suddenly got our first combination therapy. And 10 years later only did we delve into integrase inhibitors. After that followed the PrEP studies and Truvada being approved for PrEP. And then in 2014, UNAIDS looked at the 1990 targets, which were launched. And a year later, the World Health Organization released the guidelines regarding ARVs for all. So we've come quite a long way, and it's taken a very long time for us to get to where we are now with ARVs. So we're going to have a look at just the ARV classes in lumps. The NRTIs are, as you've seen, our oldest class of ARVs. And you can see that there's always been an element of weight attached to the side effects. So zidovudine was known to cause lipoatrophy. And in more recent times, we see with TDF that there's queried weight loss, and we're unsure why. But with TAF, we have noted quite significant weight gain, although to note TAF is one of the newer ARVs. We then look at the NNRTIs, and fairly insignificant. But efavirenz in recent times, and we'll delve into this a little bit later, there's this element of queried weight loss or suppression in slow metabolizers. And initially, there were reports of lipohypertrophy, which were query causal. And then in that class, if we look at doravirine, which is again one of the newer ARVs, we see again weight gain. So there seems to be this trend with the newer ARVs where instead of the weight loss that we typically saw, we're starting to see weight gain. The PIs were first flagged as drugs causing weight gain. The lopinavir, ritonavir, atazanavir. And initially what we saw was truncal lipohypertrophy. And for a long time, this was debated to be causal. The INTEGRASE inhibitors are probably one of our newer classes that have been rolled out in South Africa. And particularly with dolutegravir, which we'll go into, we've seen quite a bit of weight gain. So in the 2019 ARV guidelines, the goals of antiretroviral therapy always remain the same. We want to decrease morbidity and mortality and improve patients' quality of life. And that largely comes with new and improved ARVs. So what was really significant in this guideline update was the role of dolutegravir in first, second, and third line regimens. Dolutegravir is part of an integrase, a family or a class of drugs called integrase strand inhibitors. And they prevent the transfer of proviral DNA strands into the host chromosomal DNA. So commonly, dolutegravir, I think a lot of us are now fairly experienced with that. And one of the first ones in South Africa was raltegravir. There are a few others, so bictegravir and cabotegravir, which there are some studies being done, but are fairly new drugs. And if we look at dolutegravir and raltegravir, DTG is preferred over raltegravir for several reasons. And the biggest thing is its barrier to resistance. So it really is a bit of a wonder drug in its barrier to resistance. It is a once daily dose, and it's available in a fixed dose combination. So as a class, the integrase inhibitors are generally well tolerated. The side effects are commonly mild and doesn't often lead to discontinuation of the drugs. But what we have noticed and what we are concerned about is the weight gain. So dolutegravir's use was founded on quite a few clinical trials in both ART naive and experienced patients, and more recently, even in switch studies for second line. And like I said, it is very well tolerated. Patients enjoy taking it, and it has a high genetic barrier to resistance. So it doesn't break as easily as efavirenz does, and doesn't develop mutations as quickly as efavirenz does. Initially, there were concerns around neural tube defects, which have largely been debunked with the new data coming out of TSEPAMO. But it is efficacious, and it has very rapidly been rolled out throughout South Africa. So as a class, the integrase inhibitors with weight gain, it was first noted in around 2018. It was post-approval. It is thought to be a class effect, although we're not seeing it as much with cabotegravir just yet. And like I mentioned previously, dolutegravir more so than raltegravir. So at-risk groups that we've identified are women of African descent, the use with tenofovir, but specifically TAF, and patients with lower baseline CD4 counts and higher viral loads. So then we sort of pivot into ART and obesity. And this is very much a gray area. So we're going to try and sift through it and hopefully give you some practical guidance on how to manage patients and what options we have, even though we don't know everything about ARVs and obesity. What we do tend to see is that there is greater weight gain after ART initiation than with switching or PrEP. So it's thought to be potentially a return to health phenomenon where patients return back to societal norms, but there are so many unknowns. We don't have a lot of data of weight gain beyond 2 years. We don't know if it plateaus, does it continue to rise? We don't know the mechanisms. And to answer these questions, we ideally need clinical trials that are designed specifically to look at weight. And those preferably either PrEP studies or switching trials, so we avoid that return to health phenomenon. So obesity is it's a global concern. It worsens every year. It affects all countries, all of us. Obesity is defined as a BMI of over 30. And what that means is essentially an excess of body fat accumulating to the point that your health is adversely affected. BMI itself has quite a poor correlation with fat mass, but it is easy to measure. And we'll get into some of the measurements a little bit later. But there is no clear definition on what constitutes a deleterious weight gain by geography, sex, and race. So globally in 2016, about 13% of adults, so that's around 650 million people around the world, were classified as obese. And 40% of those, well, 40% on top of that were classified as overweight, so BMI of over 25. In men, constituted 11%, and in women, 13%. And in South Africa in 2016, we had 28.3% of people living in South Africa who were classified as obese. There is quite limited prevalence, unfortunately, on information for HIV positive adults, but people living with HIV, we expect to show similar patterns to the general population. So adipose or fat tissue confers risk depending on where it is in the body. If you were to gain weight, there are typically 3 different ways that you would gain weight. It could be lean muscle mass or 2 types of fat, so either visceral or subcutaneous fat. Visceral fat is fat around the organs, and it's a major risk factor for developing any cardiometabolic disease. Where subcutaneous fat, which lies just underneath the skin, is thought to be neutral, and in some studies, even protective. So fat tissue itself expands in several ways, and there's a lot of research being done into whether this is potentially the mechanism for why the metabolic effects develop in people. So hyperplasia, where you have an increase in the number of fat cells, is thought to potentially be healthy, whereas hypertrophy or an increase in size can relay dysfunctional fat cells and comes with associated pathologies. So what we see if we have this excess of fat cells is that the fat cells start to dysfunction. And when they do that, they trigger a release of adipokines. These act directly on the cardiovascular tissues and promote the development of disease. But there's also this chronic inflammatory state, which comes with insulin resistance and fibrosis, which impairs your metabolic function. We then throw HIV into the mix. So HIV itself comes with cardiovascular disease risk, and now together with obesity is very concerning. Complications can include things like hypertension, diabetes, obstructive sleep apneas, fatty liver disease, and malignancies and complications in pregnancy. So the significance of obesity, as far as we know, is that it promotes earlier death. So what studies have shown is that a 5 kg per meter squared BMI increase correlates with a risk of death that's increased by about 30%, which is horrendous. It is similar globally, and we suspect the same risk in HIV, in people living with HIV, as much as the general population. So the concern is for metabolic effects. So whether that's a result of increased fat cells or as a direct effect of drugs, particularly integrase inhibitors. So if we look at some lessons from history, looking specifically at HIV lipodystrophy. In 1996, when ARVs were still relatively new, as far as we knew, ARVs were safe. Then slowly we started to notice excessive fat or disruption of fat in people living with HIV. And a syndrome was recognized in 1998 and initially linked to the PIs. And it took quite a while to tether out whether that was a direct result. And eventually we got there. So it does sometimes take a long time before we found our way. And it's the same now with HIV weight gain. 2014, we thought that modern ARVs were safe. But 3 years later, we started to get these reports of generalized weight gain. And slowly, as we collected more and more information, we could see the drugs that it was potentially linked to. But now, 2020 up, we're sitting with so many unknowns. We don't know, or we're not sure about the mechanisms. We don't know the biology of the risk factors. Is there a hierarchy in the drug classes? Does the weight gain stabilize? Is it reversible? Is there treatment? And what are the clinical consequences? So ARVs and obesity have been linked in many clinical trials. As you can see on the left, this is quite a busy slide, but it just outlines some of the studies that have been done using integrase inhibitors and NNRTIs in both naive and switch studies. And what you can see, the purple represents weight gain that was either less than or equal to competitors. And so you can see with the TDF and 3TC or FTC, there wasn't significant weight gain. Whereas we suddenly look at the blue, green, yellow columns, and that denotes significant weight gain across different studies. And you can see here, linked to TAF and your integrase inhibitors. So this was an analysis of weight gain following ART initiation in randomized control trials. So it was a pooled analysis. So they put a bunch of studies together and looked at the weight gain across 8 different randomized phase 3 clinical trials, all with first-line ARV initiation. And this over quite a long period, so 2003 to 2015. So if you have a look at the first graph, the red top line is the weight gain over the weeks, so over 2 years, with integrase inhibitors. And you can see the difference between the PIs and the NNRTIs, which are the yellow and green lines respectively. The third graph that we look at, again, you can see that TAF, which is also the red top line, also has quite a significant trend of weight gain compared to the use of other ARVs. There was also another analysis done looking at studies between 2013 and 2015 and looked at in excess of 5,000 participants. And what they saw is that weight gain was greater in more recent trials. And this correlates to using newer ARV regimens. And the demographic factors that they associated with weight gain were similar to those seen elsewhere. So then when we consider TAF, there was one specific study that showed us that TAF in isolation caused quite significant weight gain. That was the OPERA cohort. And what they did here is they switched TDF to TAF whilst maintaining all other ARVs. So you had patients on integrase inhibitors compared with those on NNRTIs as compared to those on protease inhibitors. And across the board, you could see that, so if you have a look at this little box here, you could see that across all the arms, with a switch to TAF, instantly there was weight gain. What was interesting is that this weight gain slowed or plateaued over 9 months, but it does support TAF as an independent contributor to weight gain. The advanced trial, we looked at dolutegravir with either TAF or TDF as compared to the initial standard of care for first-line ARVs, which was an efavirenz-based regimen. These were all ART naive patients. And it looked at 1,053 participants. And what we saw was that DTG regimens were not inferior to efavirenz. DTG was slightly better tolerated because of the side effect profile. But what was quite shocking was the weight gain data that we got out of it. So at 96 weeks, we could see that on the group that used DTG and TAF in combination, there was on average a 7.1 kg increase in weight. So this compared to DTG with TDF, which was 4.3 kgs, and then the standard of care, which was an efavirenz arm, where patients gained 2.3 kgs on average. So quite significant changes in weight. And this so far has continued to rise with no plateau noted just yet. women more so than men tended to gain weight. And again, if you look at these, this just shows different studies and the different regimens. And again, you can see in women, particularly in that pink or purple bar, you can see that they gain significantly more weight on DTG with TAF. So NAMSAL, very similar study, looked at DTG versus efavirenz. So again, comparing what are now our two first-line options. It was a randomized controlled trial done in Cameroon, enrolled about 600 patients. And again, weight gain was greater in the DTG arm at week 96. So we continue to see that the integrase inhibitors with or without TAF are causing significant weight gain. ARIA was a clinical trial done globally, had patients from 12 different countries, South Africa being one of them, and looked at treatment-naive female adults. It ran over 48 weeks or about a year, and it looked at dolutegravir versus one of the PIs, so atazanavir, ritonavir. And again, what we saw is that there was significant weight gain with dolutegravir, and some of the other baseline characteristics that they noted that were associated with this increased weight gain were Black participants, elevated baseline viral loads, and low baseline CD4 counts. Again, this just continues to show. So a lot of these are in here for reference. So the slides will be made available and you can go and look through, but it just goes to show that there have been many randomized controlled trials around the world that continue to show these increased weights. Okay, so what are some of our theories? Like I mentioned earlier, it is quite a gray area. So a lot of these are theories. They are under investigation. We don't have any solid ideas, which makes it quite tricky when it comes to treating our patients. So some of the theories include a return to health phenomenon. Is it potentially induced by the integrase inhibitors and possibly TAF? Or is it inhibited by some of the older ARVs? Is it an increased appetite or calorie intake? Is it to do with a reduction in physical activity? Is there more lipid storage? Or is the fat quality improved? So weight gain and ART, what we've seen is that it's associated with ART initiation and subsequent viral suppression. And how that makes sense is often if patients are virally unsuppressed, their immune systems may be under some sort of dysfunction. As soon as you start them on ARV therapy and give that immune system time to heal and reestablish, you see that they often do gain weight. It's also been associated, like I've mentioned, with the newer ARVs, so those particularly introduced in the last 10 years. And it's the greatest with the integrase inhibitors between the drug classes. So the return to health theory. So the link between weight gain and baseline low CD4 is, like I mentioned, as soon as you start ARV therapy, there is an element of immune recovery. And what the body would have initially perceived as a stressful event where it needed to use fat stores suddenly restores that weight back to what it would be without HIV. But what we think is that in some patients, this might overshoot the mark. So instead of storing what their baseline would be, if they are prone to obesity for either dietary or genetic reasons, that they could gain more weight than what would be their baseline. So with advanced HIV disease, which we don't see as much as we did initially, there is definitely weight loss and an increased metabolic demands. So as soon as you stop that viral replication, you suddenly have lower energy requirements and weight gain by replenishing those depleted fat stores. There is also the element of alleviation of HIV-associated inflammation. And then also starting ARVs hastens the resolution of opportunistic infections and potentially GI dysfunction. So potentially we have improved appetite and nutrient absorption. So then there's another theory about increased appetite, and this pertains specifically to the integrase inhibitors. One of the theories was that the integrase inhibitors bind specifically to this little hormone MCR4, which is a receptor that helps with our appetite. And so by binding to that, there's an increased food consumption and increased adiposity or fat distribution. But what they found in studies and in cells is that it only seems to be affected at very high concentrations. So it doesn't seem likely that this would happen from a normal dosing schedule. The other theory is the flip side. So was weight gain inhibited by older drugs such as TDF and efavirenz? The thought here is that there was potentially a higher drug exposure with these older drugs. So in essence, we have less weight gain. Potentially GIT symptoms. Was it an element of lipoatrophy? And what was interesting that we saw in ADVANCE was that the patients who were extensive efavirenz metabolizers, so if they had any polymorphisms at the CYP2B6, and I know that's very technical, but basically if they metabolized that efavirenz to such an extent that there wasn't a lot of it left in the body, they had similar weight gain to patients who were on dolutegravir regimens, whereas those who were slow metabolizers seemed to have slower weight gain or suppression of weight gain. This theory was not largely debunked, but slightly debunked. The theory was that there was potentially a change in your calorie intake with or without a change in your metabolic rate. And this very small study looked at 30 people living with HIV who were ART naive and put them onto ARVs, and then looked at their body composition and their fasting metabolic rate. And they couldn't find any significant changes in your resting metabolic rate or the calories that they would take in. Another of the theories is that there's a reduction in physical activity. So again, based on a study that looked at people living with HIV with weight gain more than 5%, and it was just an observational cohort. So they'd identified the patients and then watched them. The average age was 54 and predominantly men. And some of them were switched to integrase inhibitors, others had no switch in ARVs. And what they could see that there were specific attributable factors which contributed, which are things that we've noticed before. So CD4 ratio, and one of the interesting ones was physical activity, which reduced slightly. There is also a concern about the adipose tissue. So is there a change in the type of fat or your fat quality? This was a study done on monkeys and looked at these 19, it also looked at 19 people living with HIV, so done in 2 populations, and looked at the fat size, the fat cell size, as well as the amount of fibrosis. So if you remember earlier, I'd mentioned 2 different types of fat. So fat under the skin, as well as visceral, which is around the organs. And what they noticed in patients who were exposed to dolutegravir or raltegravir is that there was an increase in the fibrosis, as well as an increase in the fat cell size, which we think correlates with poor fat quality and a higher risk of metabolic disease. And then some seem to think that there might be an improved fat quality. So another study, which was done in Italy, it was also an observational study where they just looked at patients. They found that obviously, like we've seen, those on integrase inhibitors had bigger jumps in their BMI, but they had a decrease in their visceral adipose tissue. So therefore, potentially better quality fat. So how they looked at it, they used DEXAs and CT markers and were able to quantify the different types of fat and where the fat was sitting. And what they noticed was an improvement in the visceral adipose tissue, which is the fat that is specifically connected to metabolic disease. So again, it is very, very vague. There are a lot of theories. There are no absolutes at this point. And even with long-term consequences, we don't have enough data to give hard and fast rules. So what we do know is that the return to health phenomenon does appear to be protective. Increase in fat may increase the risk of cardiovascular disease and diabetes, particularly in women and younger patients, and especially if that fat gain is abdominal fat gain or visceral fat gain. So in the advanced trial, there was a small increase in the risk of developing diabetes too, but the overall risk remained low. So no hard and fast conclusions drawn there. And there was no associated risk of cardiovascular disease that we could find. There is the increased risk of non-alcoholic fatty liver disease, which promotes the development of other metabolic disorders. And we don't know, is the weight gain reversible if we switch ARVs? Since the mechanisms underlying all of it is unclear, we are not sure if this will ever be reversible. So in order to be able to quantify the weight gain and help our patients, we need to speak about measurements. So measuring the amount of fat is important for several reasons, but the human body composition is really important so that we can qualify health and nutritional status. And this helps us prevent disease development or progression, as well as monitor any treatment or intervention outcomes. And so to establish this, you need to look at several elements. We look at bone density, we look at the lean mass, which is basically your organs, your muscles, and then we look at your fat mass, which is your visceral versus your subcutaneous tissue. We have several methods available, some of them less utilized than others, but these are either direct, indirect, or doubly indirect. So this is quite a busy slide, so don't get caught up in the information. I think some of us, especially this first one, a lot of us are comfortable with a lot of these measurements. So the first big set of measurements that we are used to are anthropometry. So looking at subcutaneous fat. So this basically measures the fat under the skin, and it uses calipers at 3, 4, or 7 different body sites. And based on that, it makes these general assumptions on the assessment of percentage body fat, and it's dependent on age and sex. The issue here is often when the calipers are applied, it can change the fat, of how the fat is portrayed. So you might get slightly swayed measurements because of the methods. One that is very commonly used, well, 2, BMI and waist circumference. So waist circumference is probably the most common measure of abdominal or visceral adiposity. And the numbers that we commonly use, you have an increased risk of metabolic complications if, for men, your waist circumference is over 94 centimeters, and for women, over 80 centimeters. Another measurement we can throw in here is the waist to hip ratio. So if you have a low waist to hip ratio, generally the fat tends to be more subcutaneous or under the skin, and you will have a pear-shaped obesity. And that carries a low risk for metabolic complications. Whereas a high waist to hip ratio, or more than 0.5, generally confers that the fat is sitting more around the organs and it's apple-shaped, and that confers a high risk. But the limitations here, we cannot accurately distinguish between your subcutaneous and your visceral fat, particularly in the abdominal compartment. So we cannot actually use it as an independent predictor of cardiovascular disease. This is where the medical history of the patient comes into play. And then BMI uses height and weight measurements. And again, limitations, it can't distinguish the free fat from the body fat. So it doesn't offer us the best representation of obesity. Although that said, it is a very easy to do and commonly relied on in clinical and even epidemiological setups because of its ease of use. It is considered dependent of your age and your sex, but if you add in your age and your sex as predictors, it does actually significantly increase your predictions. So it is highly specific, which means that it's a great tool for predicting when obesity is not there. But unfortunately, patients with excess body fat are often labeled as non-obese. So you have this obesity which is underreported. And then there's some other methods which aren't commonly used, either because they need certain skills or they need certain equipment, but hopefully which will be used a lot more as we go along. So the first one is bioelectric impedance analysis, where you pass a small electrical current through the body and you measure the resistance between different tissues. So that can accurately give you a good idea of your body fat mass as compared to your free fat mass. So quickly, just to go into the different compositions. So in a body, you have fat and you have fat-free. That's what we look at when we do any of these things. Under fat, we have two different types of body fat. So you have essential fat, which is found in the heart, around the heart, in bones. And then you'll have storage fat, which is where we start to look at the fat under the skin. So your visceral adiposity, your subcutaneous adiposity, and then also the fat that is stored around the heart. So that storage fat is what we specifically want to look at when we are considering if patients are healthy or not. And then your fat-free is your lean body mass. So that's the weight of your muscles, your bones, your ligaments, your tendons, minus that essential fat that is contained. So this is the bioelectrical impedance analysis is a really good field measurement, doesn't need a lot of equipment, and it gives you a good idea of that fat-free mass. It is unfortunately less accurate in the extremes, so in fat obese, as well as low-fat athletic populations. The next measurement, which is becoming a lot more popular in clinical trials and is largely how advance determine the weight gain, is a DEXA scan. So it's excellent at measuring total adiposity and your estimated VAT, and it's relatively easy to use, which is why it's used extensively in clinical research. But unfortunately, there are limitations. So it does have size limits based on your body mass and height and width, as well as it does expose you to radiation, although very low, but this could be a problem in pediatrics and pregnancy. And then ultrasound studies. So much like any other ultrasound, waves are emitted via a probe, and this is reflected by the fat and muscle interface. So then you can get an idea of body fat percentage, and you can look at the difference between fat from dermal tissue. So this is quite nice, again, as a field-based test. It's safe, it's cost-effective, and it's portable. But limitations, much like with any other ultrasound, is that it's operator dependent and requires some element of technical training. So what can we do to intervene? According to the World Health Organization, there are several population level strategies. So one of them is to increase physical activity. And what they recommend is about 150 minutes of exercise spread throughout the week. If you have a look at this map on the right-hand side, this just shows the physical inactivity in 2010. So more than 50%, well, let's say more than 40% is indicated by the red zones. And as you can see, South Africa is sitting right smack bang in the middle of that. And then on the opposite end is to reduce the intake. And this is specifically with energy like fats and sugars. But there is no clear superior diet based on systematic reviews of specific diets. So if you have a look on at this graph on the left-hand side, this table, this is what the American Society uses as guidelines for management of obesity. This was from 2016. And if you look at the categories, it's rated normal, overweight, obesity, and then with different factors. So this is quite nice because what they do is use BMI, which is nice, easy to calculate, but they also add in a clinical component. And this sort of drives the management that would be considered. So if you have a look, overweight is more than 25, but stage 0, so the lowest of those categories, is that there are no obesity-related complications. And these can be things like diabetes or pre-diabetic states, hypertension, cardiovascular diseases, dyslipidemias, all the things that we would consider complications. And then it moves up. So obesity more than 30 without complications, and then extending into a higher BMI, but with the presence of one or more obesity-related complications. And so any BMI over 25 kgs per meter squared should initiate evaluation. So important to evaluate for the presence of any complications, And then the management. So it starts with lifestyle modification therapy and then comes into weight loss medications. So that would be as soon as either your BMI is over 30 or over 25 with other complications. Remember, this is definitely first world orientated, but I think it's something that we're going to probably see a lot more of in the next few years. And then obviously at the bottom of that spectrum is the option for bariatric surgery. Again, very much a first world thing, not very common in South Africa. If we're looking at ARVs themselves, potentially looking at other ARV options, and to note, there is no evidence currently of a reversal of that weight gain after switching ARVs. So efavirenz-based regimens or NRTIs, potential to switch to rilpivirine-based regimens, unfortunately, cannot be co-administered with rifampicin-based TB therapy and cannot be started in patients with viral loads over 100,000, but a good option. And then the newer agents like doravirine, islatravir, cabotegravir. So these are all on our shores. They are coming soon. We just need some studies. Doravirine, unfortunately, may also be tainted by weight gain. We're going to have to see if it's as much as dolutegravir or not. And then islatravir and cabotegravir are still under study. Another important thing to think about when addressing weight gain is cultural sensitivity. So underweight traditionally attracted a lot of stigma, largely because it was linked to HIV and TB. And on the opposite end of that spectrum is being overweight has connotations pertaining to wealth and status. So very important to keep in mind the patient's cultural views on weight gain and trying to adopt a Western, ideally, a Western form of medicine, but being really culturally sensitive. And then there are also the ethical implications. We, at the end of the day, do want to allow patients to make informed decisions. But I think what's really important is that where we deem there to be a clear harm over benefits. So for example, the development of things like diabetes as a result of weight gain, I think it's really important for us to use our clinical discretion to help patients along. And then there are drug therapies. So this is what I'd alluded to. Again, this is very much still first world, not going to be in South Africa for some time as part of the government programs. But the FDA, actually in the last few weeks, has just approved semaglutide injections for chronic weight management. So it mimics a hormone that helps regulate your appetite and food intake. But it is also very important to note it's used in conjunction with therapies like we noted above, so lifestyle and dietary modifications. So the take-home message, obesity is a concerning side effect of many of the newer ARV options. And whilst the mechanisms around weight loss and gain are poorly understood, it makes tailoring ART to our patients quite tricky. But our advice would be a case-by-case basis, trying to consider all the factors that we have available, using all the measurements that we have available. So whether it's a BMI or a waist circumference, but using that in conjunction with the patient's genetic history and risk of development for cardiovascular disease, and using all of those factors to try and help us make the best decisions for our patients. Thank you.
Thank you, Bronwyn. I think we have 50 minutes and it was quite an academic sort of fact-intensive presentation. So it might actually be quite helpful for participants to ask questions now while we still have it fresh in our memories. So we're just going to give you a few minutes. If you'd want to ask questions, please ask your questions and we'll try our best to answer them. And then we'll move on to the case studies.
Okay, so I see one here where Dr. Martine Khan had asked, does TAF cause weight gain or is it the absence of TDF which causes the weight gain? So if you remember, there was a slide on one of the studies that was, so OPERA, which was a switch study, which looked at TDF as a baseline with the same background ARVs, so whether it was an integrase inhibitor or a PI, and switched patients across to TAF. And what they saw is the weight gain. So it looks like it's independent of TDF, but again, there seems to be an element of TDF causing weight loss or weight suppression. We're not sure why. It's something that we're trying to tease out, but TAF itself does look like an independent contributor of weight gain.
Okay, so oh, there's another question. Let's take a look. Okay. So the question is, would switching from dolutegravir to rilpivirine show any benefits? Bron, what do you think?
So again, it's tricky. We don't have enough information. I think it's something that we'll probably collect more data on the more we do switch patients. But for now, it's quite difficult to say. What we have seen with some of our patients in the clinic setting is that switching them from DTG and TAF to DTG and TDF for some patients does have weight loss. For others, it doesn't really. So it's so difficult to say. And this is largely driven by the fact that we don't know why people are gaining weight on DTG. So we can't specifically say. So it might be an option to try if that is available and you are really concerned and the patient is eligible for rilpivirine. It might be an option to try, but again, case by case basis. Very important, dolutegravir still has such a high genetic barrier to resistance. So it is still quite superior in suppressing HIV and, you know, potentially for a longer period of time. But in terms of weight gain, we don't know case by case patient.
Okay, I see there is another question. This is from Jean-Marie. Could dolutegravir discontinuation on a type 2 diabetic patient who has become obese on both treatments in less than 2 years? So I think it's, if you have a patient that's diabetic, they've become obese, would it help to discontinue the drug?
Yeah, again, it's so tricky. I think if the patients have, you know, you've gone into lifestyle and diet, so looking at specifically at their diet, if there's anything that you can adjust there, if you have done that, you have done exercise or just increased physical activity, and there's still no improvement, you know those patients better than anyone else. And I think especially if you are following them up quite carefully, it might be an option to try. If they might be open to switching to one of the PI regimens, it might be an option. But again, we don't know. So we all have to use our best clinical acumen. I think if we're asking these questions, we have already been thinking about the implications of things like diabetes long-term and weight gain long-term. And yeah, might be an option. It also might not cause weight gain. Weight loss.
Yeah. And the thing to remember as well in your diabetic patients that are on metformin, the maximum dose on dolutegravir is 500 milligrams BD, because dolutegravir actually increases the metformin dose. So, so it can cause some toxicity. So in your patient, if they're not controlled and you want to increase dose or add a second agent, it definitely might be a good idea to swap them to another regime.
Absolutely.
Okay, just give 2 more minutes and then we'll move on to the second presentation. All right. Okay, I think you can carry on posting questions. I'm just going to move on to the case studies in the meantime. I want to share my screen. Share it. Okay, great. So you can all see that. You don't have to look at my face. I'm coming off. Oh, we have some more questions, Bronwyn. We have some more comments. All right. Consider if they are on insulin, consider using GLP-1 RAL. I would love to use that. I must say I'm quite excited about it. Okay, so I'm quite excited about any anti-obesity drugs, as you can imagine. All right, so we're going to go on to our case presentations, case studies. I'm calling it weight changes on ARVs, and just something to keep in mind. A lot of the stuff at the moment when it comes to obesity and ARVs, we actually don't have any conclusive evidence. So I'm kind of going to be honest, and I'm going in a particular direction, and just sort of come with me. I'm not saying that what I'm sharing is the only truth, the absolute truth, but it's just something we've noticed in our patients in our study. And for me, it makes sense. So this is definitely a good option. Okay, just my little disclaimer. So let's just get into it. Okay, so we're going to start off with the first participant. There's 2 cases. And this patient, she's a 49-year-old female, and she started on an efavirenz-based regimen in 2008 in February. When she started off, highish CD4, 440, her weight was 62 kgs. She had a nice, healthy BMI of 25. WH staging at that stage was 1. Okay. She comes in 6 months later, in October 2018, and she's lost weight. Her weight has gone down to 54 kgs. So there's a 12% loss of weight from baseline. And according to her, she's actually been progressively losing weight over those 6 months. And I know that if you are treating any HIV patient, you absolutely just, your heart just drops whenever you see loss of weight, because there is something wrong here. Okay, so that was obviously, and the first thing we always think of, it's TB. So she's screened negative for TB. She wasn't coughing, no systemic symptoms, just the weight loss. And when chatting to the patient, she'd actually had multiple bereavements recently, and that is what she attributed the weight loss to. And I mean, we always ask, are you trying to lose weight? Never assume that weight loss just happens. But anyway, so she said that she'd had lots of people dying recently. She didn't have a big appetite to start off with, and she just generally wasn't a big eater. So we left it at that. Okay, and so the question is, how would you work up this patient at this stage? I think a lot of us are like, it's TB. We need to find the TB, because 12% is quite a lot, especially if she's not intentionally trying to lose weight. Okay, so I sort of went for the second one. I was like, shame, she's stressed and she's sad, just give her some time, And then the other thing that's always at the back of your mind is malignancy. Is there something happening here? She's 49 years old. She's already at risk. Yeah, so we just went in a little bit, not too much into that, but she didn't have a family history of cancer. She did complain of 1 or 2 sort of red flagged symptoms. She had dysfunctional uterine bleeding, and it was intermittent. Okay, she was 49, perimenopausal, and she had a pap smear done, which showed a low-grade squamous intraepithelial lesion. Again, nothing terribly significant there. And she'd also been complaining of back pain. So we sent her off for an L-spine X-ray, which is normal. And while she was there, let's do a chest X-ray and rule out the TB. And everything was fine. Clinically on examination, really could not find anything. There was no hepatosplenomegaly. There was no lymphadenopathy. Her chest was clear. We couldn't palpate her thyroid. Her vitals were normal. So she comes back the following year, June 19, and this weight loss is progressive. Okay, she's now gone down to 48 kgs. And again, clinically, we cannot find anything in this lady. Just keeping in mind that as part of a clinical trial, we often and more regularly do safety blood. So we, every 3 months, I think at this stage, and then every 6 months, we were doing full blood counts and LFTs and calciums and all that sort of stuff that was just included in the trial. And those were all normal. Her CD4 was above 400. Her viral load was always suppressed. So it's like, what now? So we have a couple of options that are available to us. So we could investigate more aggressively for malignancy. And I'm hoping a lot of you would not do the second one, start her on a course of TB treatment, because we know it's TB and it's hiding somewhere. So why not just start on TB treatment and maybe we just can't find it. And the other thing we could think of as well, biopsychosocially, does she have an underlying psychiatric condition? Is there depression? Does she have anorexia? Do we need to investigate that further and possibly treat? Right. So we went on, examined her a bit further. So her niece, so she had a few people dying. She had another person die. Her niece had apparently recently demised from cancer. She didn't know what type. So we sent her for an abdominal ultrasound. That was normal. I mentioned the FBCs, LFTs, and some other biochemistries had been normal throughout the visits. At this stage, we actually did a thyroid function test, and that was normal. We even did some tumor markers, sort of the very baseline tumor markers, which came back as normal. To be very, very, we tried everything. We looked for occult blood stool, and that was normal. Her CD4 was 460. And her viral load was always suppressed. She insisted that she was eating normally. Again, the sort of low mood, but according to her, she was mourning a new family member. And, but she was sleeping well. There were no suicidal ideations. I think her energy levels were fine. So she kind of, she didn't completely meet all the DSM-4 criteria for MDD, major depressive, but she very much could definitely have had depression. 3 months later, her weight had gone up a little bit from 48 to 50. And there it stayed at 50 for over a year. There was no further loss of weight, at least, but she didn't gain weight either. And, you know, just in case we think we're heartless clinical beasts, she was actually repeatedly offered counseling to deal with her grief, because when she spoke to us, she voiced her feelings of feeling overwhelmed. And we kept on referring her for counseling and even to psychiatry, but she never followed through with any of these visits. And obviously good old vitamin B co, which convinced helps. But yeah, so the patients say it gives them appetite, so we routinely give that as well. Okay. So we come to the beginning of this year. She's lost weight again. So again, we're looking at a 22% loss of weight since baseline in a patient who is virally suppressed, who has a CD4 of 685. Bloods are still normal. She says she's coping with grief, but she's recently had another sister that's had a stroke. Now, this is a real patient. We're not making this up. I mean, really, my heart goes out to this lady. She really had a horrendous last couple of years. But anyway, so I give up. Really, I don't know what else to do, and I'm just going to open it up to some comments from the floor. What would you have done differently? And quite honestly, how do you recommend that we manage this patient further? So if you can hear me, please type something. I'm just going to give you a few minutes if you'd like to comment, if you think our management was absolutely shocking. That's a good one. Anna Houston says, maybe ask her to do a food diary and see what is normal for her. All right, that's definitely support group from British for Love, yeah. So I think I see this with a lot of our patients, especially the ones that are working. It's such a sacrifice for them to come to their appointments as it is. So a lot of them do not want to go anywhere else. But yes, no, definitely. Diabetes screening. Oh, sorry, I should have actually mentioned. So yeah, as part of the clinical trial, we also do fasting glucose and HbA1cs, and they were in fact normal in her, but that is a very good one. Diabetes. Oh, somebody says switch to TLD if no other contraindications. Did you refer to dietitian? No, we did not refer to dietitian. That's also a good one. So supplement would have been useful actually. Efavirenz levels from Matilda Chihaka. I like that answer. Yeah, and somebody said type of ARBs. Okay, so let's see if there's anybody else. There's some questions as well. The question's not going. Do blood glucose and HbA1c? Okay, we did do it actually, and those were normal. Do a urine lamb and consider CT abdomen, looking for psoas abscess, especially with a backache. That's great. Oh, Carol, I see that answer. Slow fast metabolizer. Okay. Just see if there's any more. I think you guys are, yeah, psychological involvement is crucial. And it really is. And like I said, we kept on offering it to her. And she was like, my boss is not going to let me off work. It's fine. I'm coping by myself. But I think we could have definitely tried harder to push that. Let's just look here. Struggling with my, here we go. There's another Q&A. Okay, I think we've done that. All right. Okay, so thank you. I think you are most definitely all on the right page. So what we decided to do at this stage, obviously our principal investigator is Francois Venter, and we in our study, dolutegravir is making everybody fat. So we decided to actually just change her medication from efavirenz-based regimen to dolutegravir. So that's what we did. Sorry, just 5 seconds. Okay, cool. I'm just going to close these chats. Okay, so we changed it. We changed her medication. That's all we did. We couldn't find anything else. No diabetes. Definitely was very likely a psychological underpinnings to that, but 20% still a lot of loss. And we changed her to dolutegravir, and guess what? She gained 6% of her weight in 4 months. This is the first time she's actually gained weight in the last 2 years. Not only that, the patient says she feels well, she's got more energy, and her mood has improved. All right, so I know you say, why am I talking about a patient who's lost weight when we're talking about weight gain? And you will see now momentarily. Okay, so we're going to just very briefly discuss weight loss and efavirenz. And it was one of the reasons Bronwyn gave as to why patients were putting weight on dolutegravir, not in efavirenz. So let's just quickly talk about that. So I think you remember from med school about drug metabolizers, that you have something called a slow and a fast metabolizer. And this is all very dependent on liver enzymes, i.e. your cytochromes. Okay, so a slow metabolizer is someone where the cytochromes not working at full efficiency for whatever reason. So the drug gets metabolized slowly. So there's a higher concentration of drug in the blood. That's a slow metabolizer. A fast metabolizer means those cytochromes are on steroids, and you have a lower drug concentration. And this has a lot of impact, especially with our drug-to-drug interactions, because some of the drugs, especially with ARBs, like your PIs, they work on other drug cytochromes, changing the metabolism, drug metabolism. Okay. So efavirenz specifically is primarily metabolized by the CYP2B6 cytochrome, which Bronwyn mentioned. And they've identified 3 genetic loss of function polymorphisms in CYP2B, which means that you have this dysfunctional cytochrome, so you're going to have higher efavirenz concentration in the blood. And I think, especially given the weight loss differences that we've been noticing in clinical trials amongst the newer drugs and efavirenz, that's sort of been a place where people are sort of focusing in on. Could it be that it's not so much the new drugs that are causing the weight gain, but that the old drugs are actually causing weight loss? Okay, so this is a sub-study of ADVANCE by Chrysel et al. And they looked at 342 participants who consented to genotyping. And they were looking specifically at the CY2B genome. And what they found was that those patients who were extensive metabolizers, which means there was more drug in the blood, they gained the most weight. And this was in those who were taking efavirenz, okay? But interestingly, the weight gain was actually similar in the efavirenz arm to the dolutegravir arm in the extensive metabolizers. And I thought this graph kind of, you know, we showed you the horrendous graphs of patients gaining weight in dolutegravir, but this kind of throws a bit of a different spin on things. So here you see in the orange, these are, okay, so obviously here patients are gaining more weight. Oh, crumbs. Patients are gaining less weight. Okay. So that's what we're looking at. So in the orange, you see that it's the extensive metabolizers who are taking efavirenz, extensive metabolizers. So these are patients who are taking efavirenz in women, and they have similar, if not a little bit more weight gain than actual dolutegravir, patients on dolutegravir. Okay, and the men, this kind of switches over a bit. And also, very interestingly, is those patients who were slow metabolizers genomically, they had greater weight loss. So this is the blue. You can see the weight loss here is, it goes down, sort of plateaus a bit in both men and women. All right, are you with me? So the converse of this was another study that was presented. It was an abstract presented at CROI in 2019, and they postulated that individuals with slow metabolite genotypes, i.e. high efavirenz in the blood, will feel better after they switch to integrase inhibitor, and in fact will gain weight. That's what they postulated. And at 24 and at 48 weeks, when they swapped people from efavirenz to an integrase inhibitor, I think they used raltegravir, they didn't actually use dolutegravir in this study, they found that those patients in fact gained weight. Okay, and these were interestingly primarily white participants, and there wasn't much of a change in black participants. So let's look at efavirenz itself. So why would having too much efavirenz in your blood make you either not gain weight, in fact, lose weight? So we know that efavirenz inhibits the expressions of genes controlling adipogenesis and lipid accretion. It reduces the release of adipokines, good old adipokines that sort of help lipid and insulin metabolisms. They also cause mitochondrial toxicity, which then could impair weight gain. Not only that, they increase the release of pro-inflammatory cytokines, which are in fact catabolic. And last but not least, we all have been told about the neuropsychiatric side effects of efavirenz. There's some nausea and vomiting and loss of appetite, which could also promote loss of weight. Okay. So our recent thinking, and a lot of what Bronwyn said, is that the newer and safer antiretrovirals actually showed associated with more weight gain than older ARBs. And as much as I do agree there's obviously that's true. We're seeing the patients put on the weight. I think there's a lot of different aspects to it, because there's been massive outcry that we are putting millions of patients on dolutegravir and they're all going to get fat, and oh my goodness, what are we doing? But I just want to just show you a different side to it, that weight gain was actually just less in patients who were on efavirenz and were slow metabolizers. So it's almost like they scored the cytochrome lottery. You know, when they started efavirenz, they just didn't put on weight. Whereas if they started the dolutegravir, they put on weight because it was a sort of a return to health phenomenon. So again, this is medicine. There's always going to be new studies coming up, and we wait for that. But I do think that a lot of it has to do with the efavirenz slow metabolizers, that we're not necessarily making people fatter by putting them on dolutegravir. It's just sort of luck of the draw. Obviously, the TAF TDF thing, there's a very strong association there. I don't actually think TAF is going to be rolled out in South Africa. And in fact, tenofovir has been associated with some weight loss as well. So I think the patients in the past who were on efavirenz and tenofovir were very lucky that they had some weight suppression, but just something to keep in mind. So it suggests that weight gain on new ART regimens is actually a return to health phenomenon rather than an off-target effects of newer ARVs from different classes on appetite or metabolism. Okay, I just take a question. I see somebody's asking that. It says if viral load is less than 50, switch back to TDF, FTC and efavirenz to see if that really was the efavirenz was the culprit. Okay, then I can do that. See daisy. Okay, so I'm just saying in this patient, and obviously this is very much anecdotal, this is case by case, and we are actually wanting to look at some of our patients that we've switched, and we'd like to sort of have more conclusive evidence. But in this case, it's interesting because you have a patient who we could not find anything wrong with her. She was only on efavirenz, and it would have really been helpful to do an efavirenz level, but we didn't. But we switched it to dolutegravir, and she immediately gained weight. So something you can do as in part of clinical practice. Okay, let me move on. Okay, my second case. So it's a bit of an opposite. So this is a 42-year-old female who's on dolutegravir. She's been on the regime for 3 years. Okay. We saw her in August 2020. She's been on medication for 3 years, and we had some clinical concerns. Her BMI had increased by 33% since baseline. So she went from 58 kgs to 78 kgs in 3 years, which is, I think, quite significant. But also our main concern is we're told when patients put on weight, they have increased cardiovascular disease risk factors. So her blood pressure, which had previously been controlled, was inching up, very borderline. Her lipids had sort of been mildly abnormal at baseline, but they were not getting better, and they were definitely not improving with diet. Okay. And obviously we asked the patients, so are you worried about your weight? And she's not. She's very happy with her weight because culturally, big equals healthy. So this patient was not interested actually in swapping medication at this stage. She's like, I'm happy with my weight. I love dolutegravir. I'm feeling good. And the question is, as a clinician, should you be concerned? So what do you consider to be a healthy weight gain or return to health weight gain in an HIV patient? And yeah, if you could please. Okay, if you'd like to comment, I'd really appreciate that. What do you think is a normal weight gain or return to health weight gain in an HIV patient? What would you consider to be, oh, it's fine, we don't have to worry about this patient? And I'll just give you some moments. Okay, so Carol says that if she goes above a BMI of 30, I would be more concerned. And yeah, to be honest, Carol, I think that is something the PIs were very worried about, because obviously some patients start off with a BMI of 30. So, you know, if they change to a BMI of 35, which is morbidly obese, would you then be worried? Is it a percentage weight gain? Is more than 10% considered to be a problem? Dr. Khan says that the patient's not worried. Yeah. Just add anti-lipid drugs. Sheikh Smody says that what he considers to be normal is 1 to 2 kgs per month. So would that be over 6 months? What if she carries on putting 1 to 2 kgs every month for the next 4 years? Yeah, hopefully not. I'm sure it would plateau. British says we need to be patient-centered. What does the patient want? Are there looming risk factors? Screen, and if no red flags, happiness prevails. Yeah, in British, I think that's, I think a lot of views that clinicians would actually take. All right, okay, so let's move on. Just going to close those chats. Okay, so let's look at what literature sort of considers a return to health. So return to health, it describes a desirable weight gain following the resolution of a catabolic infection or illness that restores body fat and protein stores. So they don't have a specific percentage. A lot of people say, I read, you know, the return to health would be your weight before you got sick. With HIV, it's a bit tricky because it's such a progressive illness, you know. What was the patient's last healthy weight? What I thought was interesting was desirable. I mean, this patient desires to weigh her current weight. And like Bronwyn mentioned, we know that ART suppression of viral load inflammation normalizes resting energy expenditure and allows weight regain. And that most large-scale ART initiation studies do show that the greatest weight gain occurs in those who are initially underweight and who had advanced untreated HIV infection, so the lowest CD4 counts and highest viral loads. So I think also with this patient, we need to know a little bit more about her before we sort of make any decisions. So a little bit of background on her. She was actually started on dolutegravir, TAF, and FTC in October 2017. Her CD4 was 2. Amazingly, her WHO staging was only 1 at that stage. And yeah, her BMI was actually not horribly low, it was 22. And like I mentioned, her lipids, when she started off, there was just like an abnormal total cholesterol 5.99. 2 years later, her weight had jumped from 58 to 77 kgs and her BMI was 29. And at this stage, her blood pressure was normal and lipids was still sort of same. There was similar to baseline. All right, we come back 3 years later to August 2020, where we started off, and the weight's the highest it's ever been, 78 kgs. Blood pressure is inching up. Her triglycerides are now 2.03, which is elevated. Cholesterol 6.06, and her HbA1c was thankfully still normal at this stage. Okay, So some interventions, some proposed interventions. I think a lot of you, with the previous patient, you mentioned the dietary changes, you mentioned the statins, and this lady as well now. So there's a couple of things you're worried about here. You're worried about her weight, you're worried about her blood pressure, and you're worried about her lipids. Obviously, you want to address all that. One could say that if she lost the weight, hopefully everything else would get better. But anyway, so I think for the blood pressure, it would be reasonable that she has a 3 to 6 months dietary lifestyle change intervention before we start medication. Referral to dietitian, and this always cracks me up because often I'll refer patients to dietitians and they'll come back to me and I'll see like their sugar's not controlled, their blood pressure's still so bad, and I'll ask and she's like, no, but I'm so much healthier now, like I have brown sugar, but the patient's still having 4 teaspoons of brown sugar in her 6th cup of tea for the day. So as much as we do want to refer to the dietitian, it's also our responsibility to see what the patient's eating and to advocate from our side. And another possible intervention is to start a statin, low dose initially. And I said all of the above because I feel like we do need to do all of the above. Okay, so 3 months later, we've started a statin, we started Zocor. She says it makes her feel horrible. Okay, I think the doctor that started her actually started on 20 milligrams of Zocor, and she wants to stop it. She hates it, it's giving her myalgias. And she's really, really trying hard like to eat healthier. And I mean, you chat to the patient, she tells you what she's eating, and she really is trying hard, but she's only lost 1 kg, and her blood pressure has actually gotten worse. It's now 157 over 97. So we definitely need to start her on a blood pressure medication. So the concern is, we've been talking about patients on dolutegravir. We worry that they're putting on weight. We worry that the weight is going to lead to high blood pressures, to dyslipidemias, to diabetes. So I say desperately comb through the literature. What can we do? Now, we have mentioned efavirenz, that in the slow metabolizers, those patients actually normalize their weight, or they can use a little bit of weight. And I think in this patient, we were just so worried about her weight continuing to climb. So we did decide to change her regimen, mostly because we just didn't want her to get fatter. That's all it came down to. And I obviously discussed it with her. And I think she agreed at this stage, oh, okay, maybe it is time to change. So we changed her from dolutegravir to efavirenz. We started her on antihypertensive. I think it was amlodipine. And obviously, remember, if you are changing from dolutegravir to efavirenz, you do need to repeat the viral load with 3 months to make sure she suppresses and she doesn't have baseline resistance to efavirenz. So that's a little aside. And what do you think happened to this patient? She comes back in May and she's lost weight. She lost 10% of her body weight just by changing to efavirenz in 6 months. So we're like, oh, this is amazing. Using a little academia to work in our favor. This patient is probably a slow metabolizer. This efavirenz is kicking in. This is wonderful. Okay, so she's lost the weight, but her blood pressure is still not controlled. So despite losing 10% of her body weight, her blood pressure is even worse. And we decided to add a second agent. And just to show you that in 3 years on dolutegravir, she'd gone from a CD4 of 2 to 852. So she did well, really well on dolutegravir. It is a phenomenal drug. Okay. And this is sort of, I know I've gone through a lot of numbers. It's just kind of just to give you a picture of what happened with the patient from when she started ARVs on dolutegravir. So you can see the cholesterol sort of went up. And in May, we changed it to efavirenz. It was still quite high. TGs sort of inched up a bit on dolutegravir. And obviously LDL, that is sort of what your treatment aim is, that you look at the LDL cholesterol. And her LDL's also been persistently elevated. HbA1c, interestingly enough, has also been slowly inching up with the weight, but she lost 10% of her body weight and it went even higher. And then, yeah, the blood pressure, we have mentioned. She gained weight, it went up. She lost weight, it went up. So why is her blood pressure getting worse? And so there's a few things in literature, but according to literature, 1 kilogram loss of body weight was actually associated with a 1 millimeter drop in blood pressure. But this is not the case in the patient. Okay, so somebody mentioned a food diary, and in this patient, we actually had a food diary, and I just thought I'd share it with you. So in August 2020, when she was at her heaviest and eating healthily, according to her, she rarely ate fast food. She had quite a bit of starchy food, it was 50% of the meal, which is sort of culturally appropriate. And she ate a significant amount, 2 to 3 portions of veggies daily, I think a few fruit, wasn't much, but 0 sugary drinks. I mean, this woman was really trying her best to lose weight. Okay. Come to May, you've put her on efavirenz. She's lost weight. Okay. She's living her best life. Her diet has just actually gotten so much worse. She's now eating fast food 4 to 6 times per week. Same amounts of carbs, but less veggies, 2 to 3 fizzy drinks per day. So it just goes to show. So in this patient, again, specifically, I do think she's a slow metabolizer. So just changing her to efavirenz from dolutegravir, she lost the weight, but her diet just got worse. And just sort of like a very brief summary of where we intervened. So in August, when she was quite overweight, we gave her Zocor 20 milligrams, some dietary changes for the blood pressure. And after she lost the weight, her amlodipine had already been increased to 10 milligrams. And we had decided with this blood pressure, she needed a second agent. And although she didn't want a statin, we kind of needed to put her on a statin. All right. I'm going to answer the questions now. I'm just sort of going to finish with a presentation. And I just thought that we are talking about weight. It comes with blood pressure. It comes with dyslipidemias. So I'm just going to very quickly look at this hypertension treatment algorithm from the SA Hypertension Society guidelines, which I'm hoping a lot of you have printed out and up in your rooms. It's very helpful, very user-friendly. And with this patient, I actually think in terms of her blood pressure, we haven't done too badly in terms of management, because she came in with a blood pressure that was sort of sitting around here, 140 over 90. So it was reasonable at that stage to give her 3 to 6 months to sort out to sort of have lifestyle modifications. She came back, her blood pressure was higher. So we started monotherapy. She's come back and her last blood pressure was definitely over 160 over 100. So again, reasonable to have 2 drugs. And obviously our goal is for her blood pressure to be less than 140 over 90. Okay, so just a reminder of a hypertensive algorithm, which I'm sure many of you are familiar with. The one we're not quite as familiar with is this. It's your framing criteria. If you do use it, kudos to you. It's actually quite easy to use. I think we just need to get into a habit of using it. So on your left, you have your framing criteria. And this just sort of just kind of tells you or stratifies the CVD risk so that you know what your treatment targets are in terms of your lipids. Okay. And so when you score the patient, it's obviously it's according to you can use their total cholesterol, their age, the HDL, blood pressure, whether she's got diabetes or something. So I've done this exercise for you, and I have scored the patient, and she actually got a 6. So her 11-year risk factor of getting heart disease is 11%. Okay. And the Lipid Atherosclerotic Society of South Africa, they also give you a treatment target. So this framing criteria is really given all her other different risk factors, and HIV is not actually included in this. They don't actually consider it to be a higher risk for your dyslipidemias and risk factors. So we've scored her at a 6, and she's actually a moderate risk. So what we're aiming for when we're treating her with a statin is we want to get that LDL less than 3. And if you remember, her LDL was sitting above 4. Okay, obviously she hasn't really received any treatment. So in our minds, we sort of have it clear, she's moderate risk. We want the LDL to be less than 3. And they've also given us a sort of a practical guide on initiating statins. And her statins were actually, her LDL, her starting LDL was actually in this category here. It was less than 4.4 all 3 occasions. And our goal is to get it less than 3. So they actually tell you, these are the statins that you can use. You can use simvastatin, 10 milligrams starting dose. You can use atorvastatin, 10 milligrams starting dose. So I think the one thing we didn't do very well with this patient was how we managed her dyslipidemia. So I mentioned the doctor started her on simvastatin 20, which obviously she got more side effects. So she could have actually, to get an LDL less than 3, which is really all we need to aim for, starting her on a simvastatin dose of 10 milligrams would have been sufficient. And other than that, atorvastatin, more also commonly used statin, considered to be a slightly more potent than simvastatin, and also has slightly less side effects. So in this patient, when we restart on a statin, we might even consider atorvastatin. And again, I think the reason why I'm sharing this case is because we actually achieved what we wanted. We wanted her to lose weight, and she lost it just by modifying her ARVs. But we didn't change the cardiovascular risk factors. Her blood pressure got worse, her lipids got worse. So as much as we get a bit fixated on drugs and what the ARVs are doing, it also comes very much down to obviously diet and exercise. And diet, I mentioned quality. This patient, she's losing weight. She's now thinking, I don't have to try very hard, and she's not eating well. So some of the sort of diets you could consider with your patients are the DASH diet. That's sort of the famous hypertension diet, dietary approaches to stop hypertension. And that's very much lots of veggies, whole grains, very much less meat or lean proteins, less sugar, less salts. Okay, so that's that. Okay, so let's go on to questions. Okay, so we have quite a bit. Okay, so Leon Levine says, I'm a bit concerned that you put her onto a drug which clearly exerts its effects due to toxicity. I've heard from other ethics that they would not support that. Okay, and efavirenz can increase lipids. Carol Sendel, thank you. Okay, Bronwyn, I think you're going to need to help me with this one. You can start a low dose of statin every second day to reduce its side effects. Okay, so that's something as well. So start low dose and alternate it every second day to reduce the side effects. Okay. Can you use simvastatin? This is Kieran Dyer. Can you use simvastatin with efavirenz? So we would rather use pravastatin or simvastatin. I'm not entirely sure about that one. If anyone would like to answer it.
I think just to address Dr. Levine's question, I think it's not specifically standard practice, and I completely agree with you. It is a toxic drug. Efavirenz has a lot of side effects. There is obviously the slow metabolizer element to it as well. I think what's important to remember is that both of these cases were part of a clinical trial, and after guidance from Prof. Venter, the switch had been between the IP arms. So the 3 arms, just a reminder, were the DTG and TAF, DTG and TDF, and efavirenz and TDF, and then obviously FDC underlying them all. And so the thinking was, or the guidance was, to switch from the DTG as well as the TAF down to one of our IP arms so we could still monitor her. But it's not to say that this would be standard practice, and it's not it's not us giving guidance that this would be what should be done in clinical practice.
Yeah,
I don't know, Joe, if you want to add.
Yeah, no, absolutely. I totally agree. And I think that was actually my point in sharing this case, is that we sort of, I think a lot of the times we fixated that it's weight loss is going to sort out everything, and it's not necessarily the case. So this patient, we did change her, she lost the weight, but her lipids and her blood pressure actually got worse. So yeah, this is more just sort of interesting cases where we changed the ARBs and we could see there was actually a change in the weight and some of those applications to that. Oh yes, sorry. Thanks, Bronwyn. That wasn't very clear. I mean, people might have gotten the wrong impression. Yeah, no, sorry. We do apologize. Please don't just change on dolutegravir to efavirenz, because it is exerting its effect due to toxicity. But yeah, like I said, we follow up the patients quite regularly, so we do monitor them to see. I think for me, what was more interesting was actually seeing the patients that had been losing weight, and we couldn't find another cause for it, and changing to dolutegravir, how their weight normalized. But yeah. Any other questions? Let's see.
I think something that I just want to throw in here as well, and it's more just a clinical case by case, but with some of our patients that have actually followed some sort of dietary and lifestyle interventions. So specifically steering away from a very high, which I think is unfortunately with our population, high refined carbs and high sugar. It's cheap, it's easy, they have strange work hours, they don't have a lot of income, and those are unfortunately the foods that they can access. And with some of the patients who have changed even just to whole grains, trying to eat more fruit and vegetables, we have seen some improvement in their health, in their general energy, in their weight, and even if they are pre-diabetic or pre-hypertensive, we've seen improvements in those factors. So I think it's really important that, I know people have suggested food diaries and things like that. It's important to spend a little bit of time trying to dissect and putting in achievable goals, I guess. So cutting down sugar slowly, cutting down carbs slowly, and trying to modify the diet so that it doesn't break the bank and that it's achievable. And I think that's an important thing for us to try and focus on as well, besides just switching treatment and adding on therapies.
Yeah, because Kruger says that with the elevated blood pressure, with the creatinine levels normal, I think in this patient they were fine. She had quite a high GFR, and TAF might have been the culprit for weight gain, and just switching to TDF or a Bacover and keeping on dolutegravir regime might have been a better option. And I do agree with you, that definitely might have been a better option, especially with her. Yeah, and unfortunately, it is something that we're going to come across a lot more in terms of obesity, and not just in our HIV patients. And yeah, definitely a massive area of research is repurposing other drugs and to use for obesity. So for example, with metformin, interestingly enough, a lot of the studies are patients that have started metformin actually have up to a 4 to 7% loss of weight. I think in this patient, her HbA1c was actually starting to go up. She wasn't insulin resistant, but that might have also been an option for her, is actually starting her on metformin if she tolerates it. Yeah, that might have helped with some of her weight loss. But to be honest, in the government sector, beside metformin, we don't really have much pharmaceutically that can help with weight loss. Right. Okay, Brian, do you have any last things? Oh, wait, Helen. Patient says, I have a patient who has what I think is tenofovir mitochondrial toxicity. She's got fatty liver infiltration and hepatomegaly. Would you consider switching her to dolutegravir? So I don't know if tenofovir itself is has a strong association with fatty liver disease. It could likely be, you know, her NNRTI. She also, is the patient obese? Does she have insulin resistance? I think that would sort of more be one of the reasons why she has the fatty liver disease. All right, I think we are going to call it. Thank you so much for listening. Again, because this is, there are, unfortunately, with weight gain on ARVs, there are just no clear answers. I just do think it's very interesting that we found that link to efavirenz and slow metabolizers, and these two cases have a very strong causal link to that. I'll answer Nana. So yeah, so that's why I think I presented those two cases. Please do not go change all your patients that are fat on dolutegravir to efavirenz, but it is interesting to see that just by making that change that she actually lost weight. So the slow metabolizing effect, the polymorphism in that cytochrome is actually quite significant in some patients. And I think, yeah, like I said, going forward, we have quite a few of these patients where we sort of changed and swapped, and hopefully we will be printing it out. But yeah, but thank you so much for listening to us. I hope you take home that, yeah, do the best you can, sort out those lipids, sort out those cardiovascular risk factors, and then hopefully the really clever scientific people are going to tell us in the next few months to a year what is the way forward. But also, I think, don't be completely panicked that you are placing a whole society on dolutegravir and it's a bit of a disaster. I don't think now is the time to panic just yet. Okay, Brian, do you have anything to say?
No, nothing else from my side. Just thank you all for spending your evening listening to us chatter on. We really appreciate it. And yeah, good luck.
Okay, so with that, I'm going to conclude the evening. Thank you very much. Good night.